Hi, good evening. I'm Dr. Philip McMillan, and today I'm going to take you through some of the nuances of a post-vax brain bleed that can occur in some young people, as has happened, cerebral venous sinus thrombosis, and some of the science behind it, and why I think that one of the big failures of the pandemic was that people only see things in black and white. I'll be highlighting the case here. This was from an article that was recently put out just in the past few days, where on the BBC News, our daughter should not have died from the COVID jab. I'll be talking about that article and also making reference to some of the science that goes around it. I'll be looking at a paper that was also shared with regards to cerebral venous sinus thrombosis with AstraZeneca vaccines at the time. This was from the UK. And again, it gives us some context as to the science as well. Additionally, I'll be showing you a presentation with regards to just the science from my point of view as to what it is I'll be looking at. So I'll be going through a few slides just so that you understand it. And then I'll be giving some thoughts about how to look at things in not just black and white, but in the context of gray. Before I start, as usual, I'd just like to encourage you to join me on my journey as we try and find ways of dealing with storm. This is part of the reason why I'm talking about this, because of spike triggered autoimmune response mechanism. What I have come to the conclusion about is, as I'm putting together the paper, I realize that in reality, what we are seeing or what we are going to see with regards to this COVID storm is going to follow a similar pattern as to what happened with vaccine adverse effects, because it's just about the amount of spike protein that was circulating. And as I reflected on it, I thought to myself, if you have a situation where there's high viral titers in the bloodstream, technically you are going to have a similar kind of risk or pathological pattern that could occur, which would take us into the COVID storm. So, as I'm working on the science, if you're interested in what I'm looking at, please join me here. This is about the four pillars of storm protection. If you want to learn more about what I think is critical, what I do, what I'm focused on, please click on the link below. I give you some information about my own journey, my own thoughts, and some explanation. And you critically can join the newsletter. And once you've joined it, that's what I want you to do. I want you to make sure you watch the first section of a new COVID storm. This is where I give you the explanation as to what's been going on. So, yes, join me for this journey and look at the links in the description. And before we start, remember, look on your screen. You should see a bell in the bottom right hand corner of your screen. That's to subscribe so that you can stay in touch and switch on notifications. So let's get into the case. And this is going to be dissected at a number of levels. And as I said, you have some people who believe that the vaccine is all saving. Some people believe that the vaccine has no benefit. I'm in the middle. I can see where there is benefit and I can see where there is risk. And my question is, why is it that this seems to get so missed in terms of understanding what has happened? Because truthfully, that was then. Where we are now is a completely different analysis of risk benefit equations. But that's a separate topic for a separate time. But even at that time in 2021, when we were just rolling it out, I couldn't understand the gambles that were occurring. And so let's take you through the case that is in reference here. So, as I said, this story, our daughter should not have died from the COVID jab. This was done on the 23rd of August, 2024. And it was the parents who were pushing for a young woman who died from the AstraZeneca COVID jab. It's important to note that this complication tends to more likely occur in this case, not that it can't happen with other vaccines, but it was very strongly associated with the AstraZeneca one. So she was only 21 and she had excruciating headaches 3 times in the week before her fatal collapse from a brain hemorrhage in March of 2021. It's important to note the date, March 2021. And the concern was that, in effect, she wasn't, or the young lady, or even her parents, were not given enough information about the risks. That's what they were concerned about. And additionally, they didn't think that the A&E doctors seemed to be aware of the emerging side effects associated with the jabs and the warnings that had been issued or not issued. And so, when the Department of Health and Social Care spokesperson said, throughout the pandemic, the health system responded quickly to reports of extremely rare cases of complications following vaccination. As usual, there's a standard lie about how many millions of lives were saved in the pandemic, but sadly, we have another one lost, but it was clearly worth it for all the millions of lives that were saved. That's the narrative that we get. I completely disagree with that narrative because it is not taking into consideration risk benefit analysis. However, let's continue with the discussion. So let's get back to the paper here. These are her parents, and who had been defending or advocating for her after she passed away. She had just started her career in film, and she was given the first dose on the 11th of March 2021. She then developed a headache and sickness by the 22nd of March. So if you notice, there is an 11-day gap before she started to have symptoms. That's important because it suggests that this was not an allergic response, because that, yeah, I mean, you can have a delayed allergic response, but 11 days after sounds like a different mechanism. And based on the autoimmune research that I've been looking at, day 11 tends to be when IgG antibodies start to be produced. And so this is the point about autoimmunity that I keep on thinking seems to get missed all the time. But let's get back to the case. So, 11 days after, she started to have symptoms. So, she had the headache and sickness by the 22nd. She went to hospital. She was given migraine tablets, despite mentioning that she had the jab recently. It's fascinating. Patients oftentimes can know what their problem is, and you have to just listen to them sometimes. And in this case, she clearly thought that this was relevant. But at the time, for people who have ever been through this experience where they asked the doctor, could the jab have been the cause? You will find that most people will discount it. Now, don't ask me why they would discount it. They shouldn't. In reality, if this occurs within a short period of time, if you don't have a clear other answer, you should have it as part of your differential. It doesn't mean that you say it's the cause, but it is part of the differential. So, as we continue again with the story, we have here in this situation. So now, 5 days later, on the 27th of March, her parents were so worried that they took her back to A&E, and there, sadly, she suffered a heart attack and a brain hemorrhage. And it was just a terrible time for them, and you can imagine their loss. They have been advocating for this situation because they wanted this to be addressed. They didn't want this to happen again, and I think that's quite reasonable. It's the responsibility of families to advocate in these situations, and the system and the health system tends to have, not tends, has a duty of candor where we will acknowledge mistakes, and therefore that's what would have happened in this case. Specifically, what the coroner said in this case was the inquest was in December 23, so it took a while. The coroner determined her death had been caused by a combination of factors: intracerebral hemorrhage, cerebral venous sinus thrombosis, and vaccine induced thrombocytopenia and thrombosis due to the AstraZeneca vaccine. So, in this case, they clearly thought that the vaccine was the cause. But if you look at the time frame, December 23, we're talking about almost 2 years, almost 3 years after the event had happened. That's one of the big problems that we have at the moment, is that in reality, when people are talking about safety and so on, and it takes a long time for the research to be done. And so you don't know. And that's the truth. And that's where I think the misinformation came in, is that you can't say that this is safe. What you can say is that based on the information we have at the present time, with short term studies, we have seen no clear evidence of concern. That's very different from saying there is no concern. And what was happening is that everybody was going around saying, listen, there's no problem. You couldn't have known. Short term, medium term, long term studies were not done. And so that is an important factor that should be reflected on when we look back at this. So going back to the case, the coroner made the point that she had died from a recognized but very rare complication of the AstraZeneca vaccine. He did not find fault with the NHS for failing to diagnose it quickly enough. So the family were concerned. They wanted to know why professionals were not informed about the risks associated with the vaccine earlier when other countries were putting a halt on the vaccine, and why appropriate diagnostic measures were not taken promptly. And this highlights one of the big issues that I think came out of the pandemic, is that the big question is, was there enough involvement of people at the front, clinicians, nurses, who were hyper vigilant to find problems? That's what I think. That's the mistake. When you're starting something for the first time, you need to be hyper vigilant. You need to assume everything could be related to it. We went the other way, where nobody would assume anything was connected with it, which is makes no sense. It requires a period of being hyper vigilant if you're going to find issues, because you can't find issues if you're not looking for them. And if you are not looking for issues, you won't see them. We still have that issue today. People are not hyper vigilant with regards to COVID complications, and issues about the vaccine. I think that's something that will come up in time as being a problem for us to be addressed. So the other part of the article was talking about whether or not doctors could have been warned earlier. So remember, she had the vaccine on the 11th of March, and the symptoms started on the 22nd, 11 days after. So when you look at the timeline here, the 15th of March, Germany, France, and Italy halt their rollouts because there were a series of incidents involving blood clots. Even though the WHO did not feel there was enough evidence to prove a link. That's pretty good from these countries. They saw a problem, they said, you know what, let's just stop. Granted, they had the fallback position that they were going to use mRNA vaccines. The 18th of March, 5 cases of blood clots in the brain, 1 death. A few cases had been identified in the UK. The 25th of March, a alert to specialist staff. Issue about number of organ donors dying from blood clots was noticed. Then 5th of April, this is someone, Ollie Akram Hawk, progressively worsening headaches. And again, he died of a cerebral venous sinus thrombosis. And by the 7th of April, the new advice had come out. So you can see that within the time frame that you had this occurring, the 11th of March was probably too early for that kind of warning to be put out. And similar to what the family says, I think it's important because a young, amazing girl lost her life. The family and the parents have put forward that she was a wonderful person, amazing girl, wasn't frightened of anything, and that she had lost her life in a situation where this probably didn't need to happen. And so that's the way that I look at it, is that even though this is a rare adverse effect, my question still goes back to the appropriate cohorts. For me, this is a simple question. And I couldn't understand why this was missed so frequently in discussions about who really was at risk and who do you then target? That's really the question. I was trying to think of an analogy, and my thought, you can tell me if I'm wrong, but somewhere in, say, the northern hemisphere, Norway, Finland, I suspect they don't have a lot of mosquitoes. And imagine if you had a dengue virus vaccine that was produced. It would be very, very valuable in countries that have high levels of mosquito coverage, and you would probably want to use it there. But if you have an area that doesn't really have mosquitoes, even if you found no clear issues with the vaccine, why would you give it to the population there? That's how I think about it. It's just practical, risk and benefit. Now, if somebody had to travel to a high risk area, like what happens with the yellow fever or even malaria, you use precautions based on their risk of exposure. And I think what happened is that everybody got caught up in the hype and they forgot who was really at risk in terms of COVID-19. People say it was everybody. That's not true. And it's important to remind ourselves that's not the data. The data was very, very clear where the large risk lay. Now, it's wrong to say that somebody couldn't die if they didn't have comorbidities, but the reality is if the risk was very low, you would still need to do a risk benefit analysis. So I went back in time to find this, and I looked at the JCVI minutes. This is a draft minutes. This was from November 2020, and they had a number of experts in there, and they were just looking at the issues with regards to the COVID vaccine. Who was supposed to be targeted? Why are they doing it? And what was the strategy going forward? And this is why I said people forgot what it was that happened at the time. And if you look at the JCVI thing here, discussion, priority groups for the COVID vaccines, the highest priority were individuals resident in care homes for older adults and their carers, and delivery of the vaccine, the BioNTech in that setting would be challenging. That's because it needed to be frozen at that time. So you can see that's where they considered that high priority group to be older people with comorbidities. And even when they reflected on the healthcare workers, and you can see here, health and social care workers, they were at increased risk of exposure as they were providing a critical service. And even then, even though they were at the front line, they were still in priority group two because they recognized that they were already exposed. And if they hadn't had serious issues by that point, there was a pretty good chance that they could be okay. And so they weren't even in priority group one, which would be older people with comorbidities, all the standard things that we saw in the data. And so this is where we were in 2020. And then the vaccine rollout started to the priority one, priority two. And I think what then happened is that it continued to roll out to all age groups. That's the bit that I found very, very surprising because I was thinking, well, this was me. I was focused on autoimmunity at the time. And I was saying that this is a viral mediated autoimmune disease. Please be cautious with regards to stimulating the immune system. Please, if you're going to use it only in people who are absolutely going to need it. That's people who are high risk who hadn't previously been exposed. Limit your targeting to that and then watch and wait. And in my view, I think that early treatment, which is not a good word, it seems, should have been used alongside it. That's how you reduce the mortality that's associated with the pandemic. And I strongly believe that if that had happened, as in some countries where they didn't get access to vaccines, the pandemic would be over. You have to remember that one of the most fascinating things that caused me to do a presentation on Papua New Guinea. This is one that I did maybe about a year ago. What happens in low vaccine regions? And it came about because I heard of a discussion. There was a presentation at a mining conference where one of the people who was presenting for a company who worked in Papua New Guinea, he said, you guys should really look at this. There is no COVID in Papua New Guinea at this point. This was now like in 2022. He says it's quite remarkable. Everybody is fine. There is no issue. This should be a case to be studied. And he was right, because only 4% of their population was vaccinated. And so what you can see there is, even though they had deaths, once they achieved herd immunity, you would then not have circulation of the virus, or very little circulation of the virus. That's the principle. And it would have been the same with younger people at the time. But it still seems to me, whether or not it was political greed and financial greed that caused people to shift away from what were the obvious priorities at that time, to just start vaccinating everybody, even though we had no long-term studies. And you can see how that worked, is that within a few months, they started to identify issues. The same thing happened with the mRNAs and myocarditis. You see issues that you didn't anticipate. And so, therefore, you have to adjust. And so, therefore, the best route is to be patient and to be targeted. That's where I hold the system to account. I still can't find a good reason why this was not followed in the context of the low risk cohorts. So, in terms of the cerebral venous sinus thrombosis, I think it's important to understand what it is about. And I've got another paper here. And again, this one here was published in the UK. And this one was talking about a young woman in her mid 20s admitted with a headache, and which ultimately led to a diagnosis of cerebral venous sinus thrombosis, again, 10 days after receiving the first dose of AstraZeneca vaccine. And again, it was a similar pattern there, in that she was in her mid 20s, received the first dose in the beginning of 2021. They didn't say the date. 10 days after, she then presented being unwell for about a week, severe headache. Then she had nausea and vomiting. And on the day of admission, she then suffered a generalized tonic-clonic seizure. Now, it's important to note the difference between this young lady and the one before. The one before had headaches and nausea for about 5 days or 7 days before she presented with changes in her neurological status. And what I was saying is that it's very difficult for A&E, because they see people with headaches all the time. Everybody has a headache. Have you tried any tablets? They'll ask. No. Have you been to your doctor? No. What are you doing in accident and emergency? Can you please go home? That's the kind of thing that people are struggling against, and they face that every single day. So someone coming with just a headache is not going to warrant a significant CT scan unless there are other signs to suggest it. What was different with this person is that she had a seizure along with it, and her conscious level changed. So, absolutely, she would have a scan. And it's not just a scan of the brain that is needed, because a normal CT scan, unless there is a big clot, may still not be noted. You still have to do further investigations, ideally a venogram, where you light up the venous sinuses, in order to be able to see a clot in that region. And I'll show you some images in the presentation in just shortly. And so it's important to note that it is a rare condition, it doesn't come up very often. And it is something that I don't think would have been easy for somebody in accident and emergency to be able to identify. So let me just take you through a few slides, just so you understand a little bit about the condition. And I will also try and explain what I think is the mechanism, and why, in reality, this is going to link to a storm. You have to remember, as I said, the spike triggered autoimmune response mechanism is all about what is happening in the body after it's exposed to high levels of spike protein. You may think that people are no longer really taking their boosters, so it's not an issue. But in reality, what is happening is that people are getting recurrent infections with high circulation of virus. That's what's concerning me, because the mechanism of disease could follow a similar pattern. Let's look at these slides here just for a minute. So, cerebral venous sinus thrombosis is a rare form of stroke that occurs when a blood clot forms in the brain's venous sinuses. So, this is the principle of a venous sinus thrombosis. And here is an image of what a brain looks like. And you can see here that this is the brain. And on the surface of the brain here, blue represents the veins, red represents the arteries. So the blood supply comes in through the arteries, it goes through the tissues, and then it comes out through the veins. The veins then collect it, and it's like a motorway. This is an A road going into another big motorway, which then connects to another motorway, and this then comes out. This is how the blood drains out of the brain. So this is the system that the body will tend to use in everybody. That's what's there, what's in place. Now, the primary causes of this are usually things like blood clotting disorders, can increase the risk of clots, infections. Some infections, like the sinuses, ear infections, meningitis, can lead to CVST, which is cerebral venous sinus thrombosis, oral contraceptive pills, certain medical conditions, and head injury as well. These are just some of the causes, not all of the causes. But just to let you know that a lot of things can cause it, and it's not common. So it's not something that you see every day. And so you have to have a high index of suspicion that somebody could be having this. If, say, for instance, their headache is very, very bad or something, this is what it could look like. This is not necessarily a venogram, but it shows you how the venous sinuses are highlighted. This is the superior sagittal sinus to the transverse sinus and the sigmoid sinus, and it drains out. And this is where the big veins, and usually if there is a clot in any one of these big veins, this is where the symptoms usually come from, and this is where it can lead to bleeding in the brain. Here's another angle of it. And you can see here at the top here is the superior sagittal sinus, one of the bigger ones, going into the transverse sinus and the sigmoid sinus. And then underneath, there's an inferior sagittal sinus. And they all come together. They all come together to to connect together. Symptoms, as I since jumped forward, headache is usually very severe, different from typical headaches, visual disturbances, seizures, new onset seizures is a red flag, focal neurological deficits, that's like weakness or numbness in one part of the body, altered consciousness, nausea, and vomiting. Now, the problem with these symptoms, and I can just imagine some people thinking, oh my goodness, I've had all of these symptoms. No, I mean, the headache usually is not like a typical headache. This is like the worst headache you've ever had, and you won't be having it for 3 or 4 weeks or months. And so it's not that kind of situation. And a lot of the symptoms, as I said, are quite nebulous. And so it has to be a high index of suspicion, but it is rare. It's not a common thing. So most people who are having headaches will just be migraine. There's a very small percentage where this could be something far more serious that needs to be addressed. I've got a picture of what it would look like if there was a bleed on the brain. And this is not specific to cerebral venous sinus thrombosis, but this is a CT scan, and it's showing you the white part is the skull, and then anywhere that is bright inside the brain, so the brain tends to be darker, this is fluid, tends to be the darkest, but blood tends to light up as bright. And so this is what it could look like if somebody had a bleed. This one is not likely to be a venous thrombus. It's probably an intracerebral bleed from an artery. But this is what it could look like if somebody was to have that situation occurring. So it is quite a serious thing. And as I mentioned, just another image to help you see the picture of the venous sinuses. So this is the main one going down and connects here. Then they're connected. So the inferior sagittal is connected to here. They then drain all the way out, and then it goes into the jugular veins. And so this is the picture in blue as to how this venous sinus, and you can have a clot almost anywhere in this, even in the cavernous sinus, and it causes different kinds of symptoms. They probably, if you have it up here and it blocks some of the main veins and increases the pressure, that's when you can have a bleed in the brain. So it is significant with regards to what happens. Now, I'm going to stop the presentation just for a short while to bring you back to the case that I mentioned before, where this young lady had these headaches and turned out to have cerebral venous sinus thrombosis. And what they had said here, I'm just trying to get all of these pieces in place here. So you can see here now, again, she had the AstraZeneca vaccine at the time, and they're talking about the efficacy. And by the end of June 2022, 433 cases of thrombosis with thrombocytopenia were reported out of an estimated 49 million doses. So the point they're highlighting there is that it is rare. However, the truth is that very often many cases that are less severe could have been missed. So this number could be significantly higher. And the JCVI advised under 30s in the UK to be offered an alternative vaccine instead of the AstraZeneca, but they continued to use it in the older cohorts. Now, in the case of this young lady, you can see that at the time she was conscious. 15 means that she was alert and conscious. Her temperature and all her observations were fine. But 7 hours after admission, she had an episode of loss of consciousness with seizures. This is then where she was then treated more aggressively. All of her blood tests that they mentioned, they're largely okay. Inflammatory markers were only slightly up. The only thing they found was undetected subclinical hyperthyroidism. Now, usually at this point, that's an important flag because that indicates to me, I didn't know what was the cause of hyperthyroidism in her case, but there's a strong possibility that this could have been autoimmune. And what it means is that she may have already had an autoimmune condition in the background in this person. That's very, very important when I'm talking about storm and the issues that can come about, especially with autoimmunity. In this case, luckily for this young lady, she was discharged after 4 days with mild headache and feeling better. They kept her on long term blood thinners, and I think that after a while, she was fine. And interestingly, she was deciding whether or not it was safe for her to have her second dose of a COVID vaccine. And it was deemed not appropriate to receive the second dose of the AstraZeneca, and an alternative vaccine was recommended. You know, it's quite remarkable when you think about it. You know, after having such a serious event in somebody 21 years old, now she did have an underlying autoimmune trigger, it seems, so maybe she was worried about that. But they were very, very, very low risk. Remember, in terms of risk, you had men 60% to 40%. So out of 100 people who died, 60 of them would be men, 40 would be women. Of the 40 who were women, they were likely to be much older with comorbidities. If you went down your line out of 100, you would find less than one would probably have died if they were young, female, healthy. A very small percentage. That's really the point I was making, is that these were very low risk people, women especially, because as I said, men had slightly higher risk than women, 60 to 40. But a young woman with no comorbidities, I still can't grasp. And you still find people today who will defend that and say that was the right thing to do because there was a risk. Listen, in medicine, normal medicine, there are risks for everything, but it's a risk benefit analysis. I'll give you an example. Now, say for instance, somebody who had an irregular heartbeat and they were found to have atrial fibrillation. Your natural thought would be you must therefore put them on blood thinners, anticoagulation. But no, they need to hit certain criteria. They need to score on age, on comorbidities, on whether or not they've had a previous stroke or TIA. If they are young, even with atrial fibrillation, you don't anticoagulate them. And that's because there's a risk benefit analysis. And this is the same here. If you do a risk benefit analysis, it's not that it cannot happen, it's about the risk of it occurring and the risk occurring with intervention. And this is the point that people seem to not be able to grasp. Medicine is always about risk benefit analysis. That's just how it works, and you are always thinking about what that is. So, in terms of getting back to the paper, what I wanted to highlight in this paper here was to do with the pathophysiology. So they were noticing that there is a similarity in presentation for patients who have vaccine-induced thrombotic thrombocytopenia and those with heparin-induced thrombocytopenia. This is a condition, heparin-induced thrombocytopenia, where patients are put on blood thinners, heparin injections, and instead of it thinning their blood, it creates this reciprocal autoimmune reaction where they end up getting and making clots. So it's very important to know. And heparin induced thrombocytopenia, as they highlighted here, is technically autoimmune. It's caused by the production of IgG class platelet activating antibodies that recognize heparin and platelet factor 4 complexes. And this is what then causes the platelets to clot and cause the bleeding. It's autoimmune. So again, there's a reason why I had highlighted to you the time frame. For the first young lady, it was 11 days after being vaccinated that she had her symptoms start. And for the second person, it was 10 days after. And that fits with an autoimmune process because normally the class switch from IgM, and these are big antibodies, to IgG, which become the long term antibodies and which you produce far more of, is about 11 to 14 days. So at about day 10, 11, that would be when that switch is switching over. And that fits perfectly with the fact that spike protein triggers autoimmune responses. This is what I've been saying for the longest while. And if you don't grasp that, this is where you will not make sense about storm. I keep on making reference to this. Spike triggered autoimmune response mechanism. The presentation is going to be different from it was, but it is going to most likely follow the pattern that we have seen in the past with regards to vaccine injuries. And this is what I just realized this as I was putting the paper together. I realized actually, most likely, what I'm going to see is the complications that we had seen in the past. It's just that now it will be connected with infection and there will be a delayed response in some cases, even when infection can be mild. So, this is why I'm looking out for that. So let me tell you about this autoimmune process that I think is relevant. So I'm going to show you again some pictures here. This is the spike protein of the virus. This is what it would look like, a mock-up of it. And normally it uses ACE2 to bind to it to enter into cells. Now, what's interesting about this spike protein is that it also binds to a number of other normal proteins. There's DC sign, neuropilin 1, there's furin, just to name a few. And actually, when you look in more detail, the entry receptors it can use are ACE2, CD147, and neuropilin 1. It's quite remarkable for this virus that came from and wet market. But anyway, and attachment factors, C-type lectins, heparin sulfate, and phosphatidylserine receptors. So all of these proteins, and these are not all of them, even the estrogen receptor is one of them, can bind to the spike protein. This is a real problem. And this is why I've been looking out for autoimmunity. Now, truthfully, I was focused on ACE2 autoimmunity as the cause for severe COVID-19. But when you think about the number of other proteins that can bind to it, that's when you realize the seriousness of what we can be facing. Here is a picture of a clot. This is just a blood vessel here. So this represents the endothelial cells on both sides. Inside here is the plasma. These are the red blood cells. These bits here are fibrin and platelets are in there. And this is how a clot would tend to form. And then this clot would stick to the wall. And if it gets big enough, it could block the flow of blood inside here. But this clot could then dislodge and go somewhere else. But that's just the basic mechanics of what happens with a clot. Now, this is relevant in the context of the sinus venous thrombosis. And this is now just a picture of a platelet. This is what it looks like, kind of. It's again round, and it's showing you the things that can activate the platelet, which will then cause it to release these granules, which will be prothrombotic to trigger a thrombotic reaction. So all of these things can trigger this platelet, including exposure to the lining underneath the blood vessel, the collagen 1 von Willebrand factor. All of these things are part of these platelets that are critical for your blood clotting mechanism. So it then leads us back to what's the connection with sinus venous thrombosis. Now follow this carefully. Remember I showed you the picture that there are some attachment factors with the spike protein. One of them is heparan sulfate. Now, what happens normally is that platelet factor 4 binds to heparan sulfate, and this interaction happens not just on platelets, but it's relevant to thrombosis and clotting, and it would then form this kind of complex. So my suspicion is that in people who have elevated free-flowing heparan sulfate and there is floating platelet active 4, then they can end up with this kind of complex. Now, it just so happens that this complex can also bind to the spike protein. This is where, in my view, the serious problem comes. And that's the bit that I think is predisposing people to this vaccine induced thrombotic kind of picture. So, what would happen, and I'll show you the steps again, the platelet factor 4 binds to the heparan sulfate. This then binds to the viral spike protein. And again, in my view, this would occur in somebody who has higher levels of free spike protein floating in their bloodstream. So all three then complex together. Now, theoretically, it could happen with the infection, but it's much more difficult for this when there's a whole virus that is present. In this case, this is just free floating spike protein combining with this combination of heparan sulfate and platelet factor 4. My prediction, and this is my prediction, is that this will then get picked up by an antigen presenting cell. The antigen presenting cell will then trigger the plasma cells to make antibodies. And these antibodies will then start to rise by about day 10 to day 14, which is when they would start to see the symptoms around the severity of the clotting and the thrombus. And this is therefore likely to be the mechanism with regards to the triggering of this kind of antibody response, because normally somebody has to be exposed to heparin first for this to happen, and the immune system is primed. In this case, they weren't exposed to heparin. So how did they have antibodies against heparin? And that's where the spike protein comes in. That is my thought as to the mechanism and the association between this vaccine-induced thrombocytopenia and the timeline. Now, it's not clear why it was so high with regards to the AstraZeneca vaccine. It is much, I think, lower with some of the other vaccines, or maybe the time scale is different, and so the association is not as clear. We'd have to go back looking at all the cases, and this is the kind of research that should have been done, where all the cases of venous thrombosis would then be analyzed to see whether or not they were vaccinated and the time frames. That's big research, valuable research. But it doesn't seem as though there is any interest in industry, public health to get those kind of scientific answers because it's inconvenient. That's the sad part about where we are at the moment, is that true science that would give us answers seems at the moment to be largely inconvenient. So that's the summary as to what I'm saying with regards to this kind of brain bleed. I think it is quite sad, and I do feel it for the family when they think about this. Is lovely, their daughter who has died. Sadly, I do think I have to agree with the coroner that I can't see any way that they could have prevented this if the system were just not aware of it. But I do think that when we look at whether or not such a young person, so early in the vaccine rollout, why there wasn't any more, I guess, caution from public health and the scientific community. I genuinely don't understand it. Maybe they didn't see the autoimmune connection. And this is why I have been always very, very concerned, very hyper vigilant, because I understand the implications of autoimmunity. It really is, in my view, the most important aspect that anybody has to look at in terms of understanding not just what is happening now, but what is likely to be happening in the future. So, in conclusion, just to remind you, this case, in my view, represents a form of a COVID storm, spike triggered autoimmune response mechanism. The characteristic of this one was tied to the fact that somebody was vaccinated within a specific period of time. But my anticipation is that we could see similar patterns occurring just in relation to infection in people who are unable to properly neutralize the virus, have high levels of IgG, therefore the virus continues to circulate, leading to viral sepsis. The viral sepsis can then, in theory, drive similar kinds of autoimmune responses. That's why I'm looking out for storm. And I'd encourage you, if you are interested in this kind of thing, to follow the research, follow what we're doing. Please remember, sign up on the link below. This is, again, my view in terms of defense. So I'm not just looking at the science, I am looking at the solutions. What can you do? Join our newsletter. You'll also get an opportunity to look at my breakdown, the first part of it in terms of the course, recognize it or risk the consequences. So please join us in this journey of science. Let's see if we can find a way forward, because ignoring the issues doesn't seem as though it's in the best interest of anyone. Everyone, in theory, could be at risk in some way, shape, or form, but granted, I strongly believe that largely the unvaccinated cohort with good mucosal immunity are unlikely to be affected. Similar to what Gert thinks, this is largely going to be an issue in the vaccinated cohort, but we still need to protect them to find answers and ways to make sure that we minimize their risks going forward. Have a great evening.